Good evening. I'm Ellen Treppe from the Office of Alumni Relations at Thomas Jefferson University, and I'm happy to welcome you to tonight's program where we'll learn more about the interplay between cannabis and mental health. Throughout tonight's talk, I invite you to share any questions you have using the Q&A button located at the bottom of your screen. We will address questions at the end of the presentation as time allows. If you don't see the button, try moving your cursor and it should appear. And now it's my pleasure to introduce tonight's speaker, Dr. Brooke Worster. Dr. Wooster completed her internal medicine and chief residency at Temple University and her pain and palliative care fellowships at Massachusetts General Hospital and the Dana-Farber Cancer Center. She is an associate professor of medicine in the Thomas Jefferson University and Sidney Kimmel Medical College and practices supportive medicine and cancer pain management as the medical director of the new Center for Supportive Medicine and Cancer Survivorship. He is active teaching faculty for the medical students, residents, and fellows, and serves as program director for the Cannabis Master's Program in the Institute of Emerging Health Professions at the Sidney Kimmel Medical College. Her research interests, for which she has earned grant support, involve the use, impact, and perceptions of cannabis in pain management and other serious illnesses. Dr. Wooster, thank you so much for joining us this evening. The floor is yours.
Thank you so much. It's nice to virtually be with all of you today. I am going to do my very best to sort of walk through in about 25 minutes, kind of the interplay between cannabis and mental health. I will kind of, as the title teases, tell you it's really not that simple. So please know that this is certainly not all inclusive, and I'm very interested actually for questions and commentary and thoughts. But I think this is kind of, not going to go away and a really good topic that all of us can kind of benefit from joining in the conversation about. Okay, so I just want to start off here because I actually get a lot of comments and questions about kind of what's the difference, right? And what's the stuff that I can buy at Whole Foods and, what are we talking about? So I think it's important to just kind of set the stage with a definition, right? So cannabis is actually, a taxonomic term that is talking about a flower, right? And so it is the genus and then species subdivided into either cannabis sativa, indica, or ruderalis, and that's basically the plant in and of itself. If you talk about sort of what United States law defines, they break apart the entity of marijuana or hemp. And really, the biggest difference is THC. You can see the components are kind of the same. It's the same flower. The delta-9 tetrahydrocannabidiol, or the part that kind of crosses your blood-brain barrier and quote unquote gets you high, is what really differentiates it if we're talking about kind of law and United States law definition. So I'm going to use the term cannabis throughout, but know that is kind of all encompassing of both of these entities. Hemp is the entity that you can get because of kind of changes in legislation related to something called the Farm Bill back in 2019. Hemp-based products are what you can buy on the internet, what you can get at a Whole Foods or a gas station or in a smoothie or whatever. And there's even sort of more nuances there, but in reality, that's kind of the biggest defining variable. So kind of, this is not new, right? Cannabis is kind of, getting a lot of popular and, scientific press now, but it's really been around forever, right? Kind of before Christ, and talking about, this had roots deep within, both medical entities, kind of biblical, religious, it kind of spread throughout the world in all kinds of different things. Hemp has really deep, no pun intended, but deep roots in the United States. George Washington was actually a huge hemp farmer. So this has kind of been here forever. And there's been a lot of interplay about it, both politically, socially. You guys might be familiar with this, just a little bit of levity here, but Reefer Madness was a movie put out, you see, in 1936. And it was actually done as kind of a political commentary at that time to steer people away from using cannabis. So just here's a little bit of the trailer for you.
These high school boys and girls are having a hop at the local soda fountain. Innocently they dance, innocent of a new and deadly menace lurking behind closed doors. The burning weed with its roots in hell.
So kind of silly, but in reality, to know that there, is very deep-seated kind of, I would say, socio-political historical trappings related to cannabis, which is kind of what's gotten us to this place. And as you can see, everybody has a take or a thought about cannabis. So, it's all over the board, but this is something that is not solely social. It's not solely medical. It's not solely political. It kind of spans the gamut in a way that really no other therapeutic that we're using or we're talking about kind of does. Which makes it interesting, but it also makes it complicated, right? The legality of cannabis, we think about it as a hodgepodge and sort of, kind of confusing in the United States, but look at it across the world, right? So Black countries here it's completely illegal, spanning to kind of the lighter teal where it's legal. And you look in the United States where it's legal with conditions, and we're not the only ones that are like that, So it is, a complicated issue around the globe, and it doesn't get any better here in the United States, right? So this changes continuously. And every time I do this slide, I kid you not, when I give these talks frequently, and I always put when I access this because it often changes. So this was accessed back in kind of mid-April, and you can see it runs the gamut, right? So more and more and more, we're seeing this, the blue states, which means it's both kind of recreational or, what I kind of like to term adult use, and a comprehensive medical. Comprehensive medical basically just means it spans the gamut of any concentration or sort of ability or availability of THC. So those are states like Pennsylvania, where I'm located right now, and the surrounding states here. Just newly, New Jersey is now kind of adult use and comprehensive. But if you look, there's a large swath of states here that are light green. And that means really what's there are only those hemp-based products, kind of the very low THC. So it's not that it's nothing, but we're not comparing apples to apples. And it's interesting because I talk to patients all the time that live in other states or share their time between other states. And, it is very different than me saying, all right, I'm going to start you on a prescription for Remeron or mirtazapine. And that's the same, doesn't matter what state you're in, right? So if I'm talking about cannabis with someone, it requires a lot more sort of nuanced understanding and guidance, I think, if we're really trying to say, I want you to be able to use this as a medical therapeutic. So a lot of the questions that I saw coming in beforehand are about the legal issue, and that's complicated too. I will tell you that both the state governments and federal government has supported all sort of efforts to allow physicians to be engaged, and nurse practitioners in states too, to be engaged and recommend or sort of partake in kind of the conversation about cannabis for medical use without really any concern of liability to yourself. It is specifically noted in the PA legislation, as well as kind of all of the other states that I'm familiar with, that you are protected from it as a physician, or certain states where there's nurse practitioners. But in the federal government, it's gone up to kind of federal courts and been upheld that it's basically kind of a part of our freedom of speech. So if you're interested and want to know more specifically, the legal questions are also very complicated for our patients, or for yourself if you want to use it, right? I have a lot of colleagues that say, I'm interested, or I have a question for you about this for myself. So it's very different state by state. It's very different about how you register, if you're going to do this medically, and even kind of the difference between what does adult use versus medical mean in a state, and what dispensaries, where are they allowed, what specific conditions, right? So we run into this all the time where someone is legally allowed to walk into a dispensary because of a condition in one state, and if they go to another state, there's not. So the federal concerns are solely around occupation and gun licensing. And so those are kind of the two big holdups there. And if you're interested, this organization, the National Consortium of State Legislatures, has actually put out a very detailed kind of rapid cycle updated information that goes into much more detail than what we talk about here. But, I think it's pertinent to understand either for yourself or for someone that you're talking to, this isn't like me prescribing you propranolol, right? This is different, and it behooves us to have a conversation because the gaps get filled by, and we'll talk about this a little bit later, by other people if we don't step in, if we're talking about using this as a medical entity. So let's step into mental health, right? And I think it's fascinating and complicated and definitely not resolved. And I'm gonna sort of asterisk this right now by saying almost every single study that has been done is either observational or a retrospective analysis of kind of large databases. In other countries, primarily Israel, some in Europe, Australia, even Canada now, they're leading the charge and doing some better clinical trials. But a lot of what we see is the idea that it's association, right? And kind of the idea that association doesn't necessarily mean causation is important to remember. But with that being said, if I'm just going to draw the dividing line between anxiety and depression, there is much more favorable results looking at its impacts or its ability to actually treat or reduce anxiety. That's a huge bucket statement. But what I mean is when we've looked at in various different studies, how does cannabis impact anxiety? And whether we're talking about a very small study that was much more interventional or some of these larger ones that I'm talking about here that are like really kind of well done meta-analyses or representative samples, primarily higher CBD, sort of on the spectrum of cannabis, higher CBD, lower THC are showing favorable responses throughout preclinical animal models into sort of, humans in either generalized anxiety disorder, social anxiety disorder, PTSD. So those are the three buckets that have kind of been more favorable to this. And when we look at either epidemiologic surveys or sort of meta-analyses, we're really seeing that there's not a statistically significant difference between people that are using cannabis and then following them over time and developing anxiety. Now, remember what I said about association and causation, and it's definitely not that simple because anxiety sort of spans, a broad swath than what I talked about here. And remember, a ton of cannabis products are very high in THC. And in fact, products that are high in THC are very well known to induce anxiety, paranoia, panic attacks, tachycardia, other things that can kind of trigger anxiety. But in a kind of guided, selected basis, anxiety looks like, of the sort of two big buckets there in mental health, that it probably is a little bit more positively impactful. So depression, this is really complicated. And I'm going to, just for sake of simplicity and our time here, I'm going to lump kind of the data that we have about schizophrenia into this same idea. Is that when we look at the association of cannabis use and the sort of development of depression, is that we are definitely seeing that the odds ratio of users versus non-users for sort of cannabis and then subsequent development of depression is higher, right? And there's a big difference between occasional use versus heavy. Heavy use is defined as sort of multiple times per week or almost daily, right? So if you're using it daily and we're following people, we're talking about like, this was a well-done meta-analysis that looked at close to 76,000 people over time, lots of different articles, different sort of scenarios, but on the whole, the risk of cannabis users also noting depression was higher than those for non-users, right? So if you look at the bottom sort of well-done JAMA psychiatry meta-analysis here, the risk of a cannabis user sort of having suicidal ideation or suicide attempts, we're jumping up magnitudes of order here now that the risk is a little bit higher. But it's more complicated than that. We certainly know that it's not so simple that cannabis use causes anxiety, right? This is very much the chicken and the egg. And when we talk about and I'll talk about this, but the endocannabinoid system, or that endogenous kind of system, that is where exogenous cannabis is active at, but also we produce sort of those kind of endogenous cannabinoids in our system where they act. It's highly intertwined with kind of all of your sort of biochemistry that is related to depression, right? So if we look at lots of longitudinal surveys where we talk about sort of what is the use of cannabis and specifically heavy use of cannabis, it has increased dramatically over time, right? If we look at just 2005 to 2016, it's increased significantly. The number of people that are using cannabis kind of often nearly daily. There's not been, a statistically significant change in the overall rates of depression, right? There is a high association between the two. So that gets to that chicken and the egg conversation. And this is what I find fascinating, right? So this is your endocannabinoid system. And if you look at in your CNS, you have a very high density of what we call CB1 receptors. CB1 receptors are specifically where both more prominently THC, but also CBD to some extent, is active in your CNS. And your endocannabinoid system in general plays a modulatory role in all of the other receptors that are associated with depression. So if we're talking about serotonin, dopamine, norepinephrine, it's not that THC is directly impacting that, but what's happening is that your CB1 receptors modulate or sort of change the levels of some of those other neurotransmitters. And so what's been posited along the spectrum is two things. One is that people are to some extent self-medicating when they reach for cannabis with this, right? Because we know that THC and activation of your CB1 receptors does change the levels of some of the other neurotransmitters in your brain. So to some extent, people say that high association is because people self-medicate. The other side of that coin is that sort of extensive or prolonged or heavy use really can impact the other neurotransmitters in your brain such that you're either creating sort of more significant depression or more treatment resistant depression, right? And so what happens when you use THC again and again and again, it actually changes, it down regulates the number or the kind of extent of your CB1 receptors or their receptivity to things, which has, like I said, that kind of downstream effect on all of your other neurotransmitters. So it is incredibly fascinating and complicated, but this is why it's not so simple. And there is definitely something there. We are really at the infancy of understanding our endocannabinoid system. So we just don't know. I think another huge kind of entity to this equation about mental health and cannabis is talking about a pediatric population, right? So there's a lot that is questioned about cannabis and pervasive developmental disorders or autism or kind of a lot of the things along that spectrum. And I am not a pediatrician, but I think this is another very controversial area where what's been done is a little bit more specific in some ways, but certainly not definitive. This is a study that just came out and it looked at kind of cannabinoid treatment for autism, right? So just a very small but proof of concept trial. And they looked at, you can see, either placebo, whole plant extract, which means it's sort of all of those thousands of phytocannabinoids that come out of the plant, or pure cannabinoids, meaning just a isolate of either THC or CBD. That's what they chose. There's other isolates you can choose, but those are obviously the ones that we always talk about. And they saw that, something about the whole plant seemed to decrease disruptive and non-compliant behaviors. However, the secondary endpoints of social responsiveness and parenting distress were not sort of favorably improved with this. And adverse events, which, is a big deal in kids, is somnolence, anxiety, or euphoria, depending on kind of how extensive that is or how you're defining it. Certainly kind of, interesting to look at. But I think the idea of a young brain being exposed to cannabis is one of the things that should be talked about more probably than 40, 50, 60-year-old brain being talked about to cannabis. And I think the idea that the majority of users are young, and how does that sort of change your brain as it's developing? And this was, again, a really interesting, again, longitudinal study. So we're talking about association, but this was looking at a large group of people that were in their teens initially, and kind of following them about cannabis use kind of ever, sometimes, or often. And then and they took it in two waves. They looked at them initially and they followed them over the course of 10 years. And 10 years later, you can see the people that were using cannabis regularly, so more than once per month, had a higher prevalence of developing some sort of mood disorder. A lot of this, obviously, you can see is driven by any sort of substance use disorder. And what often gets talked about in sort of, I would say population health and sociology kind of type associations is that, it's not that cannabis exists in a vacuum, right? If you're using this or getting this or kind of around it, there's other substances. And if you have that genetic makeup or are exposing a developing brain to this and other substances early, that you probably have a higher risk of addiction, right? Prevalence of cannabis peaks in late teens, early 20s. That's the most sort of, I would say, fundamentally kind of interesting time in brain development as far as risk of developing dependence to cannabis. So lifetime dependence risk is addiction, or is 9%, excuse me. There is no such thing as a sort of physical dependence like there is with opioids, nicotine, heroin, kind of a lot of the other things, but there is a very significant kind of behavioral association that can result in dependence. It's not nearly as high as a lot of the other things that we either prescribe or people use, but it's there. If you start using after the age of 25, the risk of dependence is extremely low. I would tell you that this is the biggest thing that I have learned kind of living in this world now for years, is that it's here to stay. My patients push me about it. Our students push us about it. And that's good. But the largest problem is that by and large, it has no interconnectedness to healthcare. So this is some of the work that we've done and kind of looking at how comfortable are we as a medical entity in talking about this. So the lower numbers are suggesting kind of that you're very comfortable up to, very uncomfortable. And you can see, for something that is a commonly used and widely available entity, we're not that comfortable, and we're really not that comfortable in vulnerable populations. I think that, what this sort of speaks to me is that we need to have kind of ongoing better options for good education about, like, what is this and what do we do with it? Because, on the left here is what we think happens, right? And on the right is what happens. So it's nothing like going into a dispensary, or going into a pharmacy and having a conversation and picking up your prescription and walking home and following the directions on the package. So this is where I think people get into kind of concerns. So how do we help? So I tell my patients all the time, right, is help me understand where you are with this. Like, I'm not asking you because you're going to get in trouble. It's like, I need to know if you have been using this or ever used it, and, where do we start along this spectrum? And do you have a reason medically to prefer a specific form as a clinician? I will tell you that there's a lot in the literature about terpenes and other things. And I will tell you, we do not know nearly enough medically about this to really even think that it should guide us in any way. I focus on THC and CBD, and I talk in buckets to people, because another problem is this is a plant, and it's driven a little bit by supply and demand. So what someone got 2 months ago in a different state is nowhere near what they're going to find today in Pennsylvania. But if I can talk to them in buckets of THC predominant or CBD predominant or sort of balanced or intermediate, at least then we can kind of be talking about, getting them something similar that they've been exposed to, or avoiding something that they've been exposed to before. Oral ingestion, we're talking about milligrams or a ratio. And to know this, inhaled is always in percentages, right? So I follow up with people too, critically. It's not just like, go have at it and then good luck, because that's where, a lot of people get either have difficult interactions with it or get disenfranchised and kind of have really bad interactions. I know that there's a lot on here, but I just want you to know this is how complicated different labels are. And it really depends whether someone is using sort of right here, this is an extract. So this is a liquid. And now we're talking about milliliters, and you can see how concentrated this is. In this small bottle, this has over 1,000 milligrams of THC. So if you're not guiding someone, that can be incredibly toxic. If we're talking about a cartridge or something that they're inhaling or vaporizing, we're talking about THC and CBD in percentages, right? This is flower. And so percentages again, and you can see it's wildly different if someone's talking about flower versus how much we can kind of artificially concentrate something in an oil. This is a capsule, and you can see these are labeled a little bit more clear so that in a very specific amount, we know exactly what someone's getting, right? In one capsule, I can tell exactly how many milligrams are in it. But to understand and be able to navigate this, if you've not kind of done it before, is confusing. So a little bit about different formulations. Inhalation. So duration of action isn't that long. Half an hour to 2-3 hours, maybe. It's very rapid onset of action, which is what I tell people. The part about this that is helpful is that you're going to know how it feels almost immediately, right? So it's the easiest product to titrate. Vaporization is much more tolerable and less detrimental to pulmonary function testing, tolerability, lung function, anything than smoking anything, right? I am not a fan of someone smoking anything. Vaporization sort of at least brings that risk down, as far as we've seen, sort of for a fairly good amount, right? In immunocompromised patients, I definitely, or certainly people with already compromised pulmonary function, I steer them away from this. Oral is hard though, right? Because the bioavailability and its time to effect is very, very different. And it also matters whether it's wrapped around food or not. So you can see, and that says 60, I'd say 45 to 120 minutes as peak effect, which you have to counsel someone to be really cautious or sort of, patient about seeing how they feel with it. It lasts longer. So if you sort of kind of overdo it, you're stuck with it to some extent for a little bit. But also that means it takes a little longer. It is also helpful if you want the duration to last longer, i.e. insomnia. People that want to use this for something to help them sleep all night, this is probably a really preferred formulation. But you can see, what someone is going to have as far as bioavailability is hugely dependent on the product itself, what you have in your stomach, what time you took it, how much you're moving around. Like there are a lot of variables to it. So to say to someone, you need to go take 5 milligrams of THC and that's going to be perfect. Like we're so far from being that precise about this. The biggest thing some people try to do all the time is just take the raw product, the flour, and eat it or mix it into something. And you're really not going to have any impact there. It needs to sort of be heated, which happens as far as decarboxylation to THCA to THC. You need some heat element for that, right? Edibles obviously are the food products that have had some heat applied to the flour, and then it's in there. I am always cautious about wrapping something in a food product because it's really hard to know how much you're getting. It doesn't mean it's not helpful, but it's just, it takes a lot more sort of guidance. Dosing, anytime someone's taking something orally and they can tell, I tell people, if you haven't been using this before, you don't want to go over 5 milligrams of THC. You might ultimately need to do that, but as a starting dose, that's sort of the ceiling that I would say. And then really kind of wait 24 hours to see how you do. Topical's lovely, especially to some extent for the fact that it has no negative impacts. It might not work, but it's sort of, a very safe product. What people tell me and where we see this as being helpful are for some more musculoskeletal pain indications, right? A very local application site, massage it in, and then wash your hands. Don't lick your hands afterwards. Don't let your dog lick your hand, all those types of things. I think the other thing to know is that within the oral product kind of area, and even with the inhaled product area, there are tons of other products that I didn't even mention here that, are kind of engineered to be quite concentrated. And that's why sort of just having someone walk in to a dispensary without any guidance, if they've not sort of done this or been familiar with it, or even Googled it and got to, weed maps or some of the other things that are really consumer driven about kind of what's what, you do have a significant kind of risk of having a toxic THC ingestion. And by toxic, I don't mean that this is going to impair respiratory function or do anything that's going to result directly in death, because it's not. It's like a safe product, but it can definitely result in significant toxicity, including, paranoia, significant cardiac effects if you induce tachycardia in someone that has, already compromised or other coronary artery disease or sort of cardiac issues. You can get to sort of, significant psychiatric complications, especially in the immediate sense while this is in you, if people aren't sort of aware of dosing and impact like that. And I say this here just to point out the fact that, this is a big deal, right? We're talking about $103 billion market size projected by 2024. So this is not getting smaller. It's getting, exponentially larger. And I think that the more that we can connect the use of this to, whether people are using it for truly medical indications or some sort of wellness or other kind of somewhat interconnected component to their medical care, it is interconnected, right? Like we need to figure out ways to actually have this more seamlessly be a conversation that we're having, a knowledge sort of sharing that we can do amongst our clinical communities so that people feel more comfortable having these conversations. But, I think that it behooves us, it behooves, patients, it behooves the people that want to use this as a consumer to know that this is only going to become more prevalent. And I hope you guys found this interesting. I'm happy and looking forward to having some questions.
Thank you so much, Dr. Wooster. We definitely have some questions. And thank you for that informative talk. I know that I learned quite a bit. And I'm just so amazed at how much perception and medical use has changed over the years. So something that, as a former substance abuse counselor, I am really interested in learning a little bit about, and it was a question that came in registration. Are there drug interaction effects that people need to be concerned about, if they're on an SSRI or an antipsychotic or something like that?
So, yes, there are, and it's very nuanced, right? It's some component of it is that a lot of those medications are just simply both metabolized by our P450 enzyme system in our liver, right? So you can, to some extent, change the levels of some SSRIs, some SNRIs, tricyclics, things that are otherwise metabolized, in the liver. But like I alluded to, that sort of complex modulation or interplay in your CNS is important to note that it does have some nuanced drug-drug interactions that we're not entirely sure exactly what that is. Here's what I will tell you is that we do know that when we've looked at pharmacokinetics of this, that regular kind of reasonable use of cannabis doesn't change blood levels of antipsychotics, which are really kind of critically important to make sure, especially for some of them that we're checking levels, and antidepressants or anxiolytics, that it doesn't dramatically change the blood levels of those. But it certainly has an interesting interplay about it. And one of the things we do see, especially with antipsychotics, is that people will be less compliant with their antipsychotic therapy at times when they're heavily using cannabis. Some of that can be because the cannabis is sort of that medicating effect and they don't like the side effects, or they don't like necessarily how they feel so much on their antipsychotic. So, it does sort of make the case to have a nuanced conversation about this. Like, I think it's wrong to say it's just all bad. because it's not. And then people are just going to use it and not tell you. And it's not just all good, because it's not either. But I think for us to have that sort of nuanced conversation with patients or family members or colleagues that sort of want to kind of explore those two, I think, it does need to happen.
And I got so excited about jumping into the questions that I forgot to mention that if any of our audience tonight has questions, please feel free to use the Q&A button down below. We have several people who figured that out already, so we'll hop into some of those questions. Are there any U.S. supported trials that are being done in the United States? And if so, where can we find information about completed studies? And if it's not available in the U.S., what would you recommend to educate the new cannabis consumer?
So really good question. And some of it is, yes, there are, right? So especially the cannabidiol or CBD based products that are not considered the same sort of Schedule 1 as a higher THC product. So there has actually been that has gone through other pharma channels and gone through phase 1, 2, and 3 studies, something specifically called Epidiolex, which is a plant-based cannabidiol product that is approved and indicated now by the FDA for refractory seizure disorders in pediatric populations. So there are trials, there still is no legal avenue to do like governmentally registered or pharmaceutically controlled trials on products that have higher THC. Now, that being said, there's a lot of kind of push and pull here. Like in the state of Pennsylvania, we are doing clinical trials that we partner with dispensaries to run, right? So we can't be distributing this and controlling it, but we can partner with dispensaries to have some of this happen. So, I wish there was a better way to tell you that even looking at like clinicaltrials.gov, right, where clinical trials have to be registered, it's not that simple. And to see what's been done, just a PubMed or even a Google Scholar search for specifically what you're looking for is helpful. Kind of large scale ongoing ones in this country, they're not happening. I mean, in Israel and Canada, to some extent they are, but we're still, really a long way away from that.
And can you talk about any known long-term effects on the brain function and or anatomy with regular use?
Yeah. So, and again, take this with a grain of salt, because it's different whether you're talking about someone that's 14 years old that's using it regularly or someone that's 45 years old using it regularly, right? So as a developing brain gets exposed to frequent cannabis, we do see that there are potentially some long-term impacts on cognitive function, memory. Short-term memory is the big one, right? And that happens anytime, depending on sort of frequency of use, but short-term memory can be impaired, but also coordination, right? This is why kind of the use and then getting behind a vehicle is a big deal and things like that. But in terms of very long-term kind of non-reversible impacts in the brain, we haven't seen that. We haven't seen it in animal models either. Definitely those CB1 receptors get downregulated with frequent use, but when people stop use and kind of then are non-users for a longer period of time, 90 days, 120 days, we see that they kind of, those receptors densities come back to sort of baseline levels. A lot of that's been done in animal models, so take it with a grain of salt, but it looks like what we're seeing is more short-term impacts. However, a developing brain that is exposed to this consistently, probably has longer term kind of developmental changes. It's just really hard to know what that is because you'll never be able to do a trial to look at like, what's the difference?
One of our attendees asked, what kind of concerns or questions should a patient have if they're considering cannabis therapy for pain and or mental health issues, but they're also practicing sobriety in some form?
So that's a really good question. And I think this is one of the unfortunate impacts of kind of the 1980s Reagan era Nixon war on drugs, right? And, whatever your thoughts about that may be, but one of the things that I think got drug in there without any substantive kind of evidence to support it is that this is quote unquote like a gateway drug, or that it's going to predispose people to use other substances. And really, we've never seen that. It is never borne out in any kind of literature that this is sort of a stepping stone to other drug use. What I will tell you that is very interesting, and this is all in psychology literature about it, is that if, and especially kind of before we had more ubiquitous kind of avenues to get this from regulated sources, what happens is more association, that if you're going to kind of the quote unquote dealer or the person that had it, and you wanted cannabis, but they also happen to have Percocet, you might try that too, right? And then that might lead into other things. If someone is sort of already known to have any sort of substance use disorder, is this a trigger to kind of go back into it? Again, it's the same idea, not in and of itself that we've ever seen. And in fact, most sort of substance use disorder programs now aren't kind of even considering cannabis a risk, whether they're going to give them the next methadone dose or things like that when they're checking urine drug screens, but it's an association use. So if someone is hanging out with that person that was their dealer or that they were using it, cannabis is often in the mix. So it's really hard to say, oh, I'll just try the cannabis and I'm going to be around all this other stuff, right? Because we know that proximity does trigger kind of a return to use. So, I think of it more as geographical location rather than substance itself to some extent.
Mm-hmm. So someone had a question about you're lumping the depression and schizophrenia together for the presentation. And so, and basically the question was around, but those symptoms are so different. So
agreed. And guys, totally different diseases. I didn't mean to make it that simple. All I was saying is probably what is happening in both of those circumstances is that it seems like obviously there is some interplay between our endocannabinoid system and the symptoms associated with major depressive disorder, the neurotransmitters associated, right? We know it's an imbalance of that and a different but kind of related imbalance in schizophrenia, right? And so the use of cannabis is so heavily interconnected with those two that it's impacting either what other medications people want to take, or are they kind of self-medicating with the cannabis because they like how that makes them feel better than their antidepressant or their antipsychotic does. So in that way, it seems like the data is a little bit more that there is a higher association of kind of major depressive symptoms or sort of psychotic episodes associated with schizophrenia when people are heavy cannabis users. And it probably has to do with the fact that they're either not taking those medications as reliably then because they didn't like it or they didn't feel that they needed it, or it's really changing kind of specifically those neurotransmitters in the brain that are triggering those symptoms, although they're very different.
Mm-hmm. And one question that kind of came up multiple times in the registration questions, and you sort of hinted on it tonight, but perhaps could you talk a little bit more about prescribing cannabis for sleep? And is that something that would be safer than Ambien or some of those? And this is coming from a non-doctor, so I'm not exactly sure how to phrase that question, but
you're spot on. And honestly, nothing is always safe all the time for everyone, right? So take this with a grain of salt, but I will tell you that, and unabashedly in my practice, and I'm dealing with cancer patients either in active treatment or survivorship or other things, one of the best entities that we have to help with sleep, depending on what's causing insomnia, really seems to be cannabis, as far as tolerability, sort of lack of interactions with other medications, lack of sort of, sedative effects, right? If someone's all of a sudden being prescribed a benzodiazepine, that has a dramatic impact on your respiratory function to some extent. An Ambien, we know over time, you've heard in the news kind of all of those, the habit forming impacts of that, as well as the things about the kind of What are people doing that they don't even realize that they're doing, right? So in a 75-year-old that may get up and not realize that they're getting up out of bed, trip and fall and break a hip, I think cannabis is a safer, more effective kind of sort of entity to try for insomnia. And you need to guide people because some THC really is needed here, right? It doesn't look like the proof doesn't seem to be kind of in the pudding with just a CBD based approach, but that's where you need to sort of say, we need some of this, but obviously you don't want to kind of overdo it there.
Now, one of the things that I learned tonight, and one of our other attendees commented on, was that sometimes the dispenserist is the one who determines dosages. And is there any sort of training or maybe
great question
regulation that's going to come along to sort of, where's the doctor is really what our attendee said.
Guys, the honest answer is, we're not there. Right. I say this to my patients, to colleagues when I'm doing these talks all the time, is like, we need to step up our game because your patients or your friends or your neighbors or whatever, they will seek out this information. And here's what happens. And we've done sort of extensive kind of focus group and kind of patient interviews to see how this happens, is that patients desperately want their physicians or their nurse practitioners or their nurses or whoever to talk about this and guide them. And then it doesn't happen. So they either get their information online, and 99% of the information that you find by Googling it lands you at something called Leafly or Weed Maps, or Reddit is a huge one for this. And not that this is all bad, but it's really just driven by other users and experiential kind of things that have no medical grounding. And then the other huge category there is, the bud tender, right? The person at the dispensary. And some states require a medical presence. Like Pennsylvania actually requires a pharmacist or a nurse practitioner to be present. Most states don't. And again, this is a for-profit industry, right? So, how often that person is there or they're sort of proactively giving guidance versus the bud tender that may or may not have a lot of experiential sort of experience about this, but certainly don't necessarily know how to wrap that into medical guidance for people. That's exactly where someone's getting their guidance from, or they're getting it from a friend or a colleague. Or, I see this all the time. My patients will say, I was in the waiting room and started talking to someone, and we started talking about it, and then they gave me their guidance. And I'm not poo-pooing that at all, right? Because that's a big sort of very helpful part about discovering sort of, what works for us in our healthcare and doesn't. But the doctors are by and large absent. And I blame us for sort of just not jumping into this in a better way.
Mm-hmm. Let's see. So it's one of our attendees was asking, why should cannabis not be recommended to immunocompromised clients if there are various forms of consumption available, including tinctures and edibles?
Oh, for sure. Recommend it wholeheartedly to immunocompromised. Just don't have them inhale or smoke the leaf or inhale the oils, right? Specifically the flower itself. Like almost always, no matter how it's cultivated, the flower contains a fungus, aspergillus. You guys know that this can kind of, when inhaled, create, especially in immunocompromised patients, a really kind of significant infection. So, I absolutely, my bone marrow transplant patients, the patients that I see on other immunosuppressant medications, no problem. I guide them to oral, to topical, to other formulations. I'm sorry if that was confusing. That's the only kind of caveat with immunocompromised.
And so what do we know about the use of cannabis for treatment of opioid use disorder?
Wow. I hope I paid whoever asked that to ask that. We're literally launching a trial this past week in conjunction with dispensaries in Pennsylvania, trying to recruit specifically patients that have opioid use disorder to look at how it may be impactful. What we have seen thus far, and again, a lot of this is association, but that people that have opioid use disorder that use cannabis are more adherent to their MAT or their medication assisted treatment for longer periods of time. So it potentially has a really helpful sort of positive impact in both the opioid sparing effect, right? Potentially for help with pain for people that are chronic pain patients, or if you kind of cross over into that opioid use disorder area, that it may, in fact, what we think it probably does is decrease in the opioid use disorder population some of those cravings, right? That it's working in your CNS, and some of those cravings actually can be decreased, as well as some of the symptoms potentially of withdrawal. So that's where it may have that impact. But we're recruiting people and doing a sort of randomized controlled trial looking at very specific formulations of cannabis that we're working with the dispensary to kind of get to them. So, I think that has of lots of different areas where people want it to be helpful. I think opioid use disorder is one that potentially can be quite helpful. And we just don't have a lot of other great treatments.
A question that came up in pre-registration and has come up tonight. Can you talk a little bit about the interplay between cannabis and Parkinson's disease?
Yeah, so a lot of what our Parkinson's patients are kind of turning to this for is really associated with a lot of the spasticity with Parkinson's, right? And some of the motor disorders. And that seems to be driven a little bit more by higher CBD. And exactly what that is, we don't know. There's some mouse models that again are showing that endocannabinoid system, specifically your CB1 receptors and the endocannabinoid, which is released in your brain from these, is something specifically called anandamide, but that has a modulatory effect on a lot of the spasticity and movement kind of impacts associated with Parkinson's, and in a helpful sort of way. Again, be careful with the THC there, because higher doses of THC can certainly sort of exacerbate some of the confusion or delirium or kind of cognitive impairments associated with sort of more end stage Parkinson's. But some of those movement things certainly seem to be beneficially impacted by the cannabidiol.
Wonderful. So this I'm trying to think of some questions that we can answer quickly in the little bit of time we have left. So someone asked, what is the half-life of cannabis? Will it affect you psychologically or physically for days or a month or?
So it depends whether you're inhaling it or ingesting it orally. And that was a little bit of sort of what I was talking about there. But, it's quite fat soluble. So it will stay in your adipose tissue for a long time, but not as an active psychological sort of substance or anything in your bloodstream. It'll just make a urine drug screen look positive, right? So it doesn't have sort of prolonged effects after use. It's sort of activity or sort of time that it's going to be in your system and impacting you psychologically is ranging anywhere from sort of what I said, 30 minutes to 2 hours, up to probably 6 to 7 hours maximum with one ingestion.
Great. So in the last few minutes that we have, I'm actually going to pull up a slide to share with the group, and Dr. Wooster, give you a chance to talk about things that are happening at Jefferson.
Oh, great. Kind of piggybacking on what I mentioned about the need for us training educated, knowledgeable professionals to, hop into this space, whether it's directly in the cannabis industry, whether it's bench research, whether it's clinical interactions with patients. That's sort of not present in this country. We are one of only 2 national programs to have anything related to this. And we're happy to be launching a master's in medical cannabis science and business, because in reality, the industry is all of these things. And it's incredibly helpful, I think, to kind of be exposed to each of these different parts to train, really the cutting edge kind of, leaders in this industry going forward. This is a master's program that is entirely sort of online through our Institute of Emerging Health Professions, primarily asynchronous, and you can pick and choose a course or 2 if you just want to get a certificate in one of them, or you can stack the medicine, science, and business together with, a research and capstone kind of project with it to really kind of get a master's in it. And I think we've seen tremendous excitement about it. And I'm really kind of looking forward to sort of seeing how this grows. We will be launching officially in the first class of people. there's some people that are taking some of the individual courses right now, but the first kind of full class with all of these new entities will be starting in the fall. So really excited about this as an offering.
Wonderful. Well, Dr. Wooster, thank you so much for joining us tonight. For all of you who joined us, thank you so much for being here, for submitting your questions. For all those questions that we didn't get to tonight, I will do my best to work with Dr. Wooster to get you answers, because some of them were, sort of deeply personal, wanted to know how to help patients. So I'm committed to helping to get those answers to you. Thank you all for joining us tonight. I hope that, let's see, get this little slide. I hope that you'll stay connected with us. You'll continue to attend our programs. We have a program coming up tomorrow night. You can get all of our programs on our website, and also invite those of you who are alumni to join the Alumni Network online platform to connect with us, with each other. And with that, I'll say thanks again, Dr. Wooster, and we look forward to seeing you all very, very soon at another program.
Thank you all for having me. Have a nice evening.